before we come to our conversation on the community responses to the Ebola pandemic, let's watch this video. I think it captures some of what took place.
We are doing door-to-door active case search of Ebola patients in Kumala town. We think this is a very efficient way of taking out the sick people from their house. According to the census, there are 8 people inside the house. We have to line them all up, see them, physically inspect them. We think this is one of the efficient way to know if somebody is sick. If they are sick, we'll take them to the CCC. I go on all sit up. So you see, as you can see, we can see them. We can physically inspect them to know that they are okay, they are well. There are no symptoms of Ebola. So that's why I said this is one of the most efficient way of doing active contact tracing and case search. You can physically see a whole family household, the whole of them. Then you can physically inspect them.
Mobile teams have played a crucial role in tackling West Africa's Ebola outbreak. They have traveled from community to community, seeking out people with Ebola-like symptoms.
Yes, loss of appetite, muscle pain, joint pain, and also headache.
They also have helped trace the people who came in contact with people sick with Ebola, so the state of their health could be monitored. Health workers have been among the people at highest risk of getting infected with Ebola since the beginning of the current outbreak. All possible efforts have been made to train them about their own protection and to provide them with necessary protective equipment.
But we have some of our colleagues in the wards who have been infected and they lost their lives. They were infected because there are no PPE in the wards. They only use gloves and apron, which is not enough protection for them. And now we are here, we are protected because we are putting out full PPEs. And we have people who are monitoring us, how to wear it and how to remove it. And we have enough clothing. They make sure it's well done.
Ebola virus can be easily transmitted from the body of a person who died of the disease and spread among mourners who touch the remains. Hundreds of frontline workers equipped with protective equipment have helped organize safe burials of people who died of Ebola while striving to respect local traditions.
It has changed a lot because at first there was so much misconception that the loved ones they bury them in mass graves and with no respect, with no dignity. But for now, when they came in, they too feel relaxed. They put their mind at ease. They know that where our loved ones are, they are buried in a safe and dignified manner. As you can see around, the cemetery is very clean, and we have people that are working 24 hours a day to see that everything works out well.
Okay, thank you. So, ladies and gentlemen, I think what we just saw was a snapshot of Ebola taking hold in a community and what the response was, and perhaps some of the challenges with the response to Ebola. So between now, we're running a bit behind time, but I'll try and make up the time. Between now and 11 a.m., we're going to hear from people at the front lines of the fight against Ebola, and then broaden that conversation to a macro yet detailed view of the bank's support, achievements, and lessons learned. So as I say, I intend to make up the time, and so I will ask you to forgive me in advance, because if I sense that an intervention is taking too long, I will interrupt. Do I have your forgiveness? Yes? We're good, right? So we'll start with the Liberian experience. As you see, I have two guests up here with me. Paramount Chief Musa Kamara, and community health worker Ekene San. And so, Chief Kamara, I'll start with you. Tell us, where is your community in Liberia?
Thank you very much. I'm from Lofa Kante, in a district called Kwaduboni District, predominantly Mandingos and 90% of Muslim.
Okay. And you, Ekene, what community were you serving?
Okay, from Soul Clinic community in Monrovia, Liberia.
How did Ebola arrive in your community, Ekene?
Thank you very much. Ebola outbreak came to Soul Clinic community through a taxi driver named Mr. Siwa, Samuel Siwa. He used to drive from Monrovia to Rabat International Airport, which is the international airport for Liberia. But then his daughter was married to a pastor on the highway, and then the mother-in-law contracted the virus from the clinic because she was a health worker, and then she quickly ran from her community and relocated to her son on the ROI highway. So quickly the daughter-in-law started catering to her, and then she was about seven months old pregnant. So when she died, the daughter-in-law also contracted the virus, and then the father, who was the taxi driver, now relocated her to Soul Clinic community, where she also brought the virus, and then she also conceived or delivered in her 7 months. When she delivered in her 7 months, the baby was also infected with the virus. So the baby was taken to the Pentecostal clinic where a lot of nurses interacted with the virus. One, Quita Moba, who was the vaccinator to the Pentecostal clinic, she came in close contact with the baby. And then one, Wilfred Saki, who was also the laboratory technician, he also came in close contact with the baby. And then all of them came down with the virus, and then the virus spread all over the community. And then when Quita Moba and Wilfred Saki were taken to the ETU, that is the Ebola Center.
Ebola Treatment Unit.
Yeah, unit. Quita Moba children also contracted the virus, one Gali Conte. And Gali came down with the virus, and then she died in the community. So she was taken first to the ETU, but because of there was no enough bed to the hospital, the ambulance brought her back to the community, and then she also passed on in the community. So we also quarantined them again. So we started checking on them as contact tracer, as active case finder.
All right then. Okay. Chief, how did Ebola arrive in your community?
First of all, thank you very much. The Ebola entered in Lofa through FOIA, March 2014. By a lady called Finda Tamba in FOIA, and she was taken to the hospital there, Burma Hospital. Then after that, she died, and other people contacted the virus. And one of these patients have to leave from FOIA to Vonjama, and they were treated by 3 nurses. One was Mohamed Kamara, and the other 2 was Koto, and that of Koto and Elizabeth. Now, this person, when he died, alarm blew from the Vera community.
You talked about one of the people being the son of a local imam.
Yes.
Make that connection, please.
Okay. The local imam in my district, Kwaduboni district, by the name Lai Bawa, that was his mother-in-law, came in a year in Monrovia, that died there. Lai was infected for that virus. So he left quickly to go to Lofa. He thought it was a traditional healing. And what people in Bakadu was in a denial because they didn't believe, they thought Ebola was a mere making. So based on that, he died too. When he died, Lai died, the father, they call Imam Molba Bawa, contacted the virus by bathing his son. And other Muslim brothers who went to sympathize with the Imam because his son died. So automatically everybody was infected in Bakedo. Then those who came from the various towns and villages to come and sympathize with the Imam, they also came in contact with it, and it was spread in the district.
You've both talked about the initial response. On your side in Lofa, didn't quite believe that Ebola was a real thing. On your side, Ekene, you talk about people hiding. How did that response then evolve to you as community workers, taking control and saying we need to do something about this?
Okay, at first, the community themselves were not involved because of the fear, okay? So later when everybody noticed that people were dying all over from all fronts, so the community, what we did was that quickly to engage the community and also recruit people from the community and train them so that they will feel that the children are part of the process. So when the children were part of the process, every one of them started to encourage them that Ebola is real. Let us do something before it wipe every one of us out. So everyone started doing the contact tracing, the active case finding, and the disease surveillance. So that's how everyone all got involved.
Chief?
Okay, in my community, after we all has gone in a denial, but when we realized that the Imam, the son, the wife, they all died at the same day, so I quickly moved to Vonjama to inform our community student, Kwadu Bone community student at the Vonjama Community College, to carry the message all over. But then the first thing we did, we quarantined ourselves. We informed the people that nobody should leave. All the chiefs were called. Nobody leave your area, and nobody go to your area. We have a ferry, we have a big river they call Lofa River. We have a ferry there, and we posted people there. Nobody could come in, nobody could go out, and that's how we quarantine ourselves in our district, and as we move on.
So in both cases, it seems as if the community responded first before the national health authorities. What did you learn from the experience? Because we recognize that the worst of the outbreak is over. We've had no cases reported since March. As people, heavily involved in your communities, what was your takeaway from the experience, Chief?
Okay, in the first place, what we learned is that we have no cause to deny the health workers. We have no cause to deny the health workers. That was the cause of the Ebola overcoming us. But after working with the health workers.
You mean you didn't work with them at first?
From the beginning, yes.
Mm-hmm.
Yes.
Why not?
Well, there was a rumor circulating, they say Ebola was mayor-making. So for that, they say, well, people want to get money, get rich out of the people. So based on that, nobody could listen to them in my community. So at the end result, when we saw that our Imam and other people are dying daily, so we decided to work with the health workers, including our superintendent of Lofa, Honorable Just S. Duno. We took advice from the government.
So your takeaway from this was to trust your health workers?
Of course.
Anything else?
Well, we will continue to work with our health workers, and we ask other donors. But for me, more especially, the way I work with the health workers, there's an international NGO they call Global Community. When they saw that the movement in Kwadu Bone of Ebola has sat down, I was invited by them, taken from Lofa County to other counties like Grand Cape Mount County, where you have predominantly Muslim, because Muslim was in a denial. So I, being a Muslim, could go and speak to the other people in their own vernacular. Because when I get there, the traditional leaders, the youth, the women, I contacted everybody. They have 5 radio stations in Grand Cape Mount County, and I pick up people who could speak their dialect in their counties. So the people there could listen to them. Forget about the feast, forget about bathing the dead body, forget about shaking hands, do not hire any patient, do not accept a stranger, and don't move away. Keep yourself after 24.
So that's an extension of trust, because it's using you as a respected community leader, but also using language.
Yes.
Communicating in languages that people can understand. Ekene, what was your learning?
Yeah, what I really learned from the past Ebola outbreak was that Ebola was not only a threat to health, but it was also a threat to economy. Because most of our investors in Liberia left the country and things became tough on our people, and there was no way for us to move forward. So what I learned that is not only to health, but it's a threat to economic security as well.
Would you say that the lessons you learned are shared broadly across both your communities?
Yeah, sure.
Yeah. Chief?
Yes.
Would you say that what you learned from Ebola was the same lesson that your community members learned as well?
Yeah, you see, it was a drama that you can't have Ebola in your community, that the next door is still open, that you people are interacting with, like Sierra Leone, Guinea. So we were interacting with those people, going from border crossing, informing the people, be careful, do not touch their body, do not accept stranger, and the rest of it.
Okay. So I'll thank you now for sharing your experiences of Ebola with us. Thank you very, very much. We will move on.
Okay. We appreciate your invitation.
Thank you
very much.
Moving on entails zooming out. And we've heard already about the response of the bank. It played a leading role in mobilizing support for the response to Ebola. So we're going to have a panel discussion on this, regional preparedness, shortly. And so for that, I will invite the ministers of Sierra Leone and Gambia, Madam Zuliatu Mamatu, the Deputy Minister of Health. If you could please take a seat up here from Gambia. The Minister of Health, Mr. Omar Say, and Dr. Sunita Pitamba, the head of the Human Development Division here at the bank. So while they prepare to join me, I will now call on Dr. Caroline Jehu Appiah. She's the bank's principal health economist, and she coordinated most of the bank's Ebola projects spanning the technical and budgetary and much more. So don't be deceived by the beauty.
Okay, good morning, everyone. Since 2014, the bank has been supporting the ECOWAS countries in their preparedness, response, and recovery efforts through 12 operations. 10 of them were for Ebola, and the 2 recent ones were for Zika. 8 of the operations have closed, and 4 are still ongoing. So my presentation basically serves to provide an overview of what has been achieved, what lessons have been learned, and what the recommendations are for going forward. So as has been mentioned by our speakers this morning, Ebola was declared a public health emergency in 2014. And there were there was an atmosphere of panic. Epidemiological projections painted a doomsday scenario. The usual humanitarian organizations that are very quick to engage in such a crisis did not initially engage. Health workers, seeing their colleagues die around them, refused to work. Bodies were piling up. So the prevailing atmosphere at the time was one of fear and paranoia. So Ebola impacted on everything. It had a social impact. It disrupted basic social services. Schools shut down, markets shut down, airlines stopped flying. It had an economic impact. We lost over $2 billion of GDP in 2014. So collectively, we all fought back. We realized Ebola wasn't as scary as we all thought. We quickly learned patients could survive and health workers could stay safe. With the right resources, the right protocols, and the right dose of political will. We lost over 500 workers in countries that have very low levels of human resources. And collectively, as I said, we fought back, and we made it on the... Oh, sorry. It's working now. I didn't realize it was working. Oops. So we made it on the cover of the Time magazine, and these are heroes. Dr. Brantley was able, he got infected and he was able to survive, so he's written a book about it. And unfortunately, we lost Dr. Khan, the only virologist Sierra Leone had. So the African Development Bank was the first multilateral development bank to rally behind the 3 countries. As soon as the international call for assistance was issued in March, in April 2014, the bank approved a 3 million grant to Guinea and its surrounding countries. The second major operation was quickly designed to support the implementation of national preparedness plans in all the ECOWAS countries and also response activities in the 3 affected countries. We quickly designed or established the Post-Ebola Social Investment Fund, which was basically to build community resilience. And then under the AU umbrella, we also had the Technical Assistance Project to build human and institutional capacity. And the recently approved 2 projects were the Zika projects for Cape Verde and Sierra Leone. So what were some of the outputs and outcomes? By far the biggest challenge was one of HR, not only in numbers, but also with regards to capacity. So we trained over 40,000 health workers in surveillance, case management, infection prevention and control, 60 epidemiologists. We trained thousands of contact tracers, surveillance officers, hygienists. We also paid incentives to the health workers. Our funding was able to do that. And then we deployed 115 ECOWAS health workers. So the outcomes basically were able to build capacity in epidemic preparedness, which was key. So case fatality dropped from 70% to 40%. We also, in terms of infrastructure, we rehabilitated and constructed 150 Ebola isolation units. Equipment was procured, vehicles were purchased. So the systems for epidemic preparedness and response had been strengthened. But that is not to say the systems are strong, and they still need a lot of support to be resilient and effective. The bank also approved a 150 million budget support operation targeting 4 countries, that is Sierra Leone, Guinea, Liberia, and Cote d'Ivoire. And its objective was basically to ease the fiscal constraints for government to do its work. And then it also contributed to the multi-sectoral approach, including nutrition, agriculture, and social protection. So our efforts paid off. And the impact is that we have 0 cases of Ebola in Liberia, Guinea, and Sierra Leone. Many lives were saved. We only lost about 13,000 people against the projections of millions of people. Health systems have been strengthened. The communities have been empowered to effectively respond to Ebola. And directly and indirectly, 221 million citizens of the ECOWAS region benefited. So what were the lessons learned? For the bank, I think the first lesson learned was that a health threat is an economic threat and a development threat. We saw how quickly the economies of these countries were brought down to their knees. The other lesson we learned was that we've been underinvesting in health systems, the consequence of which was, especially in the context of fragility. I mean, in contrast, we saw Nigeria was far better at dealing with the outbreak. Ebola was introduced to Nigeria by a traveler from Liberia. 19 people got infected, and 5 people died. So it was an incredible contrast in terms of how quickly they were able to contain it. And showing that good systems, whole of society response, strong leadership and partnership can help countries deal with Ebola. The other lesson we learned was that country ownership, leadership, and community engagement were key to success. When the country leaders took control and took charge of the situation, that's when we began to see a turnaround. Whether it was clear leadership from the president, whether it was those further down the chain of command, the community workers, that's when we began to see results. Another lesson learned was that the critical role of partnership between governments and international community. Usually, development tends to feel like a tug of war between governments and donors, but in this case, we're all pulling the same end of the rope. I remember I was seconded in 2014 to UNMIR. That's the UN agency for mission for Ebola emergency response. It was a temporary agency created by the UN and hosted in Accra. So I was sent to Accra for 3 months, and it was amazing. Initially, we didn't have any premises, so we're all camped in this big warehouse, at the WFP warehouse, where we sat around. That was when I first met Dr. Yuti. So we sat around tables. There was no hierarchy, no protocol. There were no territorial thefts to be fought. We just worked seamlessly as one team. So it would be great if we could work together and if this could be the norm rather than an exception. Another lesson we learned was that we've improved national capacities, and this is why the 3 countries can deal with the resurgences. We also learned that there were missed opportunities for sub-regional action between MRU and the ECOWAS regional bodies. And then at the end of the day, we need a long-term solution to addressing these pandemics, and we need to quickly establish the Centers for Disease Surveillance and Control. The private sector also played a valuable contribution. Over 150 companies came on board and donated over $215 million US, and these are underestimates. So we shouldn't forget that as we try to come up with solutions for increasing resources. So what next? As was mentioned by speakers this morning, every crisis presents an opportunity to build stronger and better. We need to increase investments in universal health coverage and health systems. And with a rise in epidemics, there's going to be an increased demand on health systems. So either we need additional funding or we need to find innovative approaches to deliver health services. And without a functioning health system, it's very hard for a country to end its cycle of disease and poverty. And health is so fundamental to development that even if there was no chance of another epidemic, investing in health would be a worthwhile investment. So we need to move from strategy to action and quickly establish the Center for Disease Control and Prevention, and the African Development Bank is working with partners to get it off the ground. We need to promote nationally led strategies to increase ownership and use of country systems to ensure sustainability, because at the end of the day, you have to be your own soldier. As an individual, as a community, as a country, no one can fight the battle the way you do. We also need to explore innovative options for financing healthcare. We need financing that goes beyond financing that fills financial gaps, but financing that is catalytic and can leverage private and domestic resources. We also need to improve donor coordination and harmonization, which are key principles of the Paris Aid Effectiveness Agenda. It's been 2 years since the crisis hit, and no one can say with any degree of certainty that how much was delivered or spent on Ebola. I remember the World Bank was tracking resources, the OCHA was also tracking resources, and UNMIR. But we don't have a one-stop shop that the public, governments, and partners can use. So this is something we need to improve. I think on that note, I'd like to end my presentation. Thank you very much.
Caroline, thank you for that. Once we sort out the technical problems, it might be useful once we go into roundtables, Caroline, to have aspects of your presentation projected behind us, because there's some valuable observations you make which can help guide our conversations. Thank you very much for that. And so now we've been talking about Ebola all morning. Dr. Moeti referred to other incidences of communicable diseases, and you will join us up on stage. But after this presentation from Dr. Yoti Zabulon, who's the technical coordinator from the WHO's Health Emergencies Program. He's based in Sierra Leone, and hopefully we can now move the conversation from Ebola to Zika.
Good morning. I'm privileged to make this presentation. First, today for me is a very special day, in that on the 7th of November 2015 was when WHO declared the end of Ebola in Sierra Leone. In fact, such a time we were all in one hall celebrating the day. So I'm really happy that on that same day, I'm here talking about Ebola, recovery, and talking about other threats in the region. Having worked with the 14 Ebola outbreaks over the last 17 years, I did realize really this was a bit unique, and I knew it would take a little longer than normal, in that whenever Ebola hits a place, and it is new to the place, it causes a lot of fear. It causes a lot of panic. It disrupts communities. Even if the health systems are slightly stronger than what we observed in the 3 countries. On the other side, we clearly learned that the local communities make a big difference. In fact, in DRC, Uganda, and these other places where it is frequent, the leadership by the local community is the one which stops the outbreak. We come in and work with them. So chief-led actions, community-owned actions are the way to go for this. This does not only apply to Ebola, it applies to childhood immunizations. We need to stretch this so that we prevent maternal deaths, the community ownership so that women deliver in health facilities, community action so that the immunization coverages are high. So as I speak about Ebola, as I speak about Zika, I'm really emphasizing that we stretch these lessons learned to other aspects of health in our region. Okay, so I'm just going to take us through some slides. I hope this time they will move better because I have a lot of graphs to show and maps, and if they are not going to be, I will look for a way of summarizing. But before we go into those other technicalities, 4 major things to communicate at the beginning. We, of course, made some key achievements with support from Africa Development Bank and the other partners. First, we attained 0 Ebola cases by end of December 2015. And in the past, Ebola used to kill 90% of the people, 70%, and this time we had highest number of people recovering from Ebola. This, I think, for me, is a very big achievement. Second, the investments we made on Ebola didn't only stop there. They have been sustained, especially in these 3 most affected countries, and we're already benefiting from that. As Dr. Mwete said earlier, the subsequent flare-ups of Ebola were rapidly contained and with the minimum involvement of international support. This time, the local actions contained them quickly. And this is now contributing to really detecting of events earlier. The countries are more aware, and even countries which used not to detect events are able to detect some of these very rare events as well. Let me point the case of Guinea-Bissau. We wondered why there was no Ebola in Guinea-Bissau, and yet a lot of movements were happening. But now, Guinea-Bissau is one of the countries which has been able to detect Zika, which is rarer than Ebola. So the preparedness work we did beyond the 3 countries is beginning to give us a lot of hope. Thirdly, in the whole region, we have made significant contributions in terms of preparedness and prevention. You remember, the Ebola outbreak was limited to few countries. We expected it to be worse than that. After saying these nice things, I must say that the region remains at a very high risk, so we need to do more. We need to do more in terms of preparedness, in terms of health system strengthening. What are we talking about? We had 2 tranches of investment from African Development Bank. The second one is still running on, and it is helping us to strengthen systems which were already put in place. I must say here that the support to WHO Afro and to the countries has been very useful in that we are able to work with the countries. You may realize that we need to work in a coordinated way. But if we are not, as WHO supported in terms of resources, finances, then it is very difficult to work with the countries. So we do appreciate the bank so much for that. So I just want us, after saying that, to go through some tangible achievements from that type of support. And what are the best practices I can quote? Okay, I'm told 5 minutes, so I have to run through quickly. This is that long tail of what we call epidemic curve, which started somewhere, and the red, you see the 2 red boxes are recurrences of Ebola, the flare-ups which occurred, which were rapidly contained. And then these are the 3 areas where they were contained. They did not spread widely like it did before. In Montserrado, in Liberia, quickly contained. In Zerekore and the neighboring prefecture, that was where it was contained. This is what we need, contain at the source. To contain at the source, we obviously need to strengthen surveillance system. And in the African region, the surveillance system is strengthened through what is called the integrated disease surveillance and response, which helps to identify, to report, to analyze, to investigate, and to respond timely to events. But to do this, we need to prepare well, and we need to communicate timely. So for this, we need capacities. And this slide shows, with the African Development Bank Fund, how we have been able to train 5,000 people after the Ebola outbreak for really sustaining the capacity for IDSR in these 3 most affected countries. A good example here, good coverage. Just before Ebola, red districts in Sierra Leone show where we had IDSR not well implemented, but just a few months after that, in December, over 8 months, we see whole coverage of the whole country in terms of that surveillance. Another good practice here you see is it's not only the coverage, there are quality issues as well. And one of the indicators of quality is what proportion of districts report timely to take action. So you see here the target is 80%. Before, just at the beginning and before 2015, the district reporting was way below the target of 80%. And now we have sustained this target at more than 80%. This way we'll be able to detect events early, report and respond timely. This has been because of the investment, therefore we need to sustain this, we need to invest more, especially domestic investment plus the international support. One good practice is when you have information you need to share. So analyzing data for action. I'm here happily reporting that weekly in these 3 countries we're able to get reports now, weekly reports. Here I've shown you Liberia and Sierra Leone, but Guinea does the same. With this, we're able to monitor the events better. Not only monitoring events, but what are the threats which are being picked. So you see here a number of events as suspected cases weekly, and a team gets around to analyze the information and sees if there's a threat or not. So despite these significant achievements, we still have really a lot to do in the African region. And this is the region which shows clearly that we have events. On average, 100 events per year means every 3 to 4 days we have a new suspected event reported, every 3 to 4 days. If this meeting was to stay here until Thursday, we would have reported a new event in the African region. So this is the kind of thing we deal with. Some of them we control quickly, and it doesn't reach this level of discussion, ministerial dialogue. Many of them, in fact. Some of them get verified and then discarded. But 100 events per year means 3 to 4 new events. Every week we have a new event. And most of these are infectious diseases. Over 80% means they can spread from one person to another, one country to another, one continent to another if we don't have systems in place. To help us with the prioritization and to be better prepared, we finalized the risk mapping and risk assessment. And this slide shows how frequent cholera is, recurrent. If you take 2 different years, you see the mapping is the same. It means the risk factors, which in most cases lie beyond health sector, are still there. We know where the diseases occur. We know where the risks are. So we need to just work together to manage the risks. The same here is for Ebola and the Marburg, with the countries at a very high risk. And the same here is for some other disease called Lassa and Congo Crimean fever. And then the same here is for yellow fever and the recent Zika. You see, many countries at risk, although we are talking of 2 countries only. And then here is some other disease called the Rift Valley fever, which currently is causing an outbreak in Niger. We have, of course, this risk of emerging new infections. Something starts remotely, new, but suddenly we detect it in Africa here, or starts in Africa here, it spreads rapidly. You all remember the influenza, the new strain of H1N1 came and spread rapidly in the globe. So here is another one called Zika virus, which WHO declared as public health event emergency of international concern in February this year. This was because it spread faster than it was doing before. This was because new complications were observed, neurological, affecting the brain and the spinal cord. And this was new, something like children born with undeveloped brain. Here is a photo of such a child we have recently got from Guinea-Bissau. There are studies going on to link it with Zika. And we have observed certain cases in Cape Verde as well. At the moment, no vaccines for that, no definitive treatment, therefore investment in R&D, research, so that we find out really the links with these new diseases. Zika, normally, we knew it was causing mild febrile disease, fever, and self-limiting. But with these new complications, we now know that there's a knowledge gap. The bank has supported us with $2 million US for the two countries, Cape Verde and Guinea-Bissau, and this will significantly contribute to the understanding. I'm just going to, if I can take 1.5 more minutes, I will finish. So we have, this is the global spread of Zika, mainly in the Americas. But you know how close we are. You know, this is globalization. You can have breakfast here, lunch in Europe, and supper in the US. And if you're incubating a disease, you would be able to take it around. So with the in the era of globalization, diseases move faster and more efficiently. These are the areas which are affected in Guinea-Bissau and in Cape Verde by Zika now. There are some key challenges, if I can just highlight them a bit slowly, that we have inadequate emergency preparedness. We need investment, more investment in preparedness. This is resulting into late detection and confirmation of events. And then we still have inadequate response capacities. And these emerging and re-emerging diseases need us to do more in terms of research and developing new innovative ways of controlling them. This is my last slide. We are proposing that we increase investment on preparedness, specifically through strengthening international health regulations core capacities. We need to support further risk assessments at the local level, at the district level, which should help our prioritization. Secondly, we need to promote and continue to have joint multi-sector approaches for managing risks. Thirdly, we need to invest in research, I repeat this, and increase our knowledge. Fourthly, stronger partnerships and alliances with the banks, with the communities, and with the other partners, including Africa Union, to make sure that we have Africa CDC functional. And lastly, all these rest on strong health systems. So we need to really, really deliberately and put efforts to strengthen health systems for better resilience. Thank you very much.
Thank you, Dr. Zabulon. Apologies to both Dr. Jehu-Appiah and Dr. Zabulon for rushing you. We need to make up the time, but as we go into roundtables, hopefully we'll hear a bit more detail from the work that you've been doing. Dr. Moeti, may I invite you to join us here on the panel? So we have, if we stick to time, we have only 15 minutes to hear from our distinguished panel here. I'm begging your indulgence. Let's nick, 5-10 minutes here and there, just to make sure that we exhaust as much as possible the wealth of experience and expertise that we have here. So you know already that we have the Gambian Minister of Health, we have the Sierra Leonean Deputy Minister of Health and Sanitation, we have Dr. Moeti, whom you heard from earlier, and we have Dr. Sunita Pitamba, the head of the Human Development Division here at the bank, whose team organized this dialogue. And so, Sunita, I think it's fitting that we start with you, because a lot of this work you will be following up on. So connect the dots for us. We're hearing a lot about resilience. We're hearing about the impact to health systems, but also to economic systems. What are we working with? Sorry, microphones, please.
Thank you very much, Uduak. This is a very, very important question, and as President Adesina and His Excellency the Prime Minister mentioned, we are really talking about the economic impact on Africa's growth. So in terms of what we see happening, really investing in health, and as Dr. Moeti has said, has not been sufficient. If you remember last year at the Billions to Trillions meeting, the SDGs financing meeting in Addis Ababa, we have calculated as a development community, as development partners, that we will need to invest in the trillions to be able to meet the SDGs. So in fact, for the African Development Bank, we believe that we are going to be focusing on supporting disease surveillance with the Centers of Disease Control, with the partners. And we are also going to be looking at how do we promote better health insurance, universal health coverage, because there's going to be more needs also not only specifically related to health, but also quality of life. As you know, the bank has the high fives, and the high five number 5, improving quality of life, is going to be comprehensive. So social protection, improving services delivery is going to be critical as well. And here I think with this approach, we believe that it's not only going to improve health services, better access to health care, but also will, in the long run, reduce the cost of health, access to health. Because this is one of the issues that we're constantly dealing with our high levels of poverty in Africa. How do we make access to health affordable? So these are all approaches I think that we need to think about, and with the partners, we're going to be looking at that. And I think this is going to have the impact on resilience as we go along, not very long from here, not very far in the future, but very soon. We've already started working with the partners, with the development partners, with the countries, especially starting here in the West Africa, with the ministers and their delegations, to start thinking about the Centers of Disease Control. And eventually this concept has to be launched in each of the regions in Africa to have an Africa-wide Center of Disease Control to really have that kind of impact on reducing epidemics going forward.
Right, and so that speaks to our surveillance capacity. Dr. Moeti, if I come to you, because we see that on the continent we have endemic diseases. So what happens? How do we go from endemic to epidemic to pandemic?
I think you can go from a small outbreak to an epidemic, as happened with this Ebola outbreak, simply because your health systems is not there. It's not functioning. As was amply put by the president, it is broken. So, and then there are also, if you like, epidemic and pandemic-prone diseases, which, because of the nature of the spread, if you look at things like avian influenza, you know, Ebola was nasty, but it doesn't spread as easily as some other diseases spread. So there are real risks for pandemic potential by some particular microorganisms where we need to take particular care in terms of spread. So I think the first step to having outbreaks, epidemics, even pandemics, is having weak health systems. And then the second is having inadequate preparedness systems, and not only a plan written on paper. We need to have systems that are functional, tried and tested systems where everybody knows their role.
Okay. But if we look at, and I refer to Dr. Yoti's presentation, all these diseases, sort of, bubbling away beneath the surface. So why aren't those becoming pandemics? Are those healthcare systems working, or are the communities sensitized? Are they immune? What's going on?
No, as I said, there are some microorganisms, particularly those that are spread airborne, influenzas, as we have seen, SARS, those types of diseases that can spread very quickly and cause a pandemic. Cholera, we have very many frequent, recurrent, predictable cholera outbreaks in the African region. But it's rather limited. That's spread it's waterborne. That's spread by poor hygiene and sanitation and unsafe water. So you can have small outbreaks that also are costly because they preoccupy health workers so much. We have cholera outbreaks that last for 6 months in countries, 9 months. The entire health system is spending its effort on these cholera outbreaks because the water and sanitation system is not working in the country. So we have all sizes and a range of outbreaks, and then we have the pandemics that can really devastate the whole world.
Madam Mato, I'll come to you because part of your responsibility is sanitation, and you heard Dr. Mweti refer to sanitation. What has changed in Sierra Leone as a result of the Ebola outbreak?
Thank you very much. Good morning. Unfortunately, Ebola is not something I wish to see or hear about again. But the good thing that happened is people became more aware of simple hand washing. We're still doing it, and we had the fewest number of cholera-stricken people just by that one hand washing practice. As we speak, we are doing what we call, we don't kick Ebola out of Sierra Leone, we kick Doti out of Sierra Leone. Dirt, that's what we call it, yeah. So that's what we're doing right now. This sanitation piece in Sierra Leone, let me take Freetown for example, is horrible. It is horrible. And under the Ministry of Health and Sanitation, it is my responsibility. And one thing I can promise you, by the time you go back to Sierra Leone, you will see a clean Freetown. The slummy areas are very filthy. And that's where we had the highest cases of cholera. Of course, we're scared of Zika. Sierra Leone is an endemic country, malaria prone. Malaria is caused by mosquitoes. Mosquitoes breed in filthy water. They breed in dirt. Zika, are we scared? Very, very scared. But we are prepared. We have prepared. We have the EOC, which was established during the Ebola.
Which is? Emergency
Operating Center. We do have that one. We have the lab capacity to test. We have the most prominent one is in Freetown Laka. You can test for Zika. We have 13 emergency operating centers in all the 13 districts. We have a team of nationals ready to go within 24 hours in case of an emergency. Be it Zika, be it Ebola, we are ready. We still have some gaps though. But nationally, as a nation, we are really ready for Ebola or Zika or anything that comes up.
So out of the tragedy, something good has come. And so we celebrate you for learning from that lesson. We move on to Gambia now, because we tend not to hear too much about Gambia, your health situation, your challenges. Ebola escaped you. Zika, we hope, will also find its way past you. But how does Gambia, given that it's in this sort of endemic region prone to all these disease outbreaks, how does it cope?
That's a very good question. You see, in July 2014, we had an interministerial special emergency meeting coordinated by the WHO, and then the WHO came up with a roadmap. That's what they can do. So it's up to country ownership to take ownership and leadership. One of the problems we have with these outbreaks is lack of coordination. As a country, we went back based on the WHO roadmap. We developed our national Ebola response plan. And that's one country plan. One of the problems these people have in the sub-region was mushrooms proliferation of people come in name of NGOs using their embassies. If you go to Sierra Leone today, if you go to Radisson Blu, they can tell you how many beers were sold, how many VIPs entered and go, but they will not tell you how much was invested in health system strengthening. And this is because there was a lack of coordination. Right, we hit to WHO. So the answer is, there is a WHO roadmap, there's a WHO plan. If ADB want to invest, the way forward, if they want to invest, we must build on from where we stop in Ebola and move into all hazards plan. Countries must come out with stringent measures and look where their capacities are, where there is weak, and develop action points. And then based on what WHO advises. Now, having done that, now the way forward, let me just take 2 minutes and say what I would think is, when you're investing, you don't invest in people who the next minute they will lose and we start crying attention. The people affected are the people in the communities. We have our primary health care. We are talking about universal health coverage. We have our community health nurses training. Why don't we invest in these people and knowing that 90% of these diseases can be prevented? You take people from the local community, train them, employ them, send them back to their communities. So they don't move around, they stay in countries and work. This is what we are doing in the Gambia. One. Secondly, the lab assistants, train them to a level that they can do minimal services and they stay in country and work. So this is where we invest in training. But if you train a scientist for 7 years, work for 1 month, next month he's working somewhere else. And what impact is it going to make? Secondly, there's going to be a One Health meeting in Senegal on Friday. If ADB want to invest, let's look at the outcome of this meeting, where the ministers of livestock, animal health, and the environment are coming out with recommendations. We strategize this thing, cost them, and make a roadmap for the African region. I think the way forward. Otherwise, no. Thank you.
Gosh, that's a fantastic example, really, of national ownership. I think people want to applaud you. Go ahead and applaud. And I think the thing that stands out there is the scaling up of training for community workers like Ekene there as the first line of defense. But given the examples, you're talking about donors, and then I think the point you're making is that donors eventually leave you to your own devices. And Ekene also made the point that when Ebola was at its height, the foreign investment fled. So how do you then encourage other countries that don't pay as much attention to owning their national plans and preparation? How would you encourage them to go about that?
See, the guidelines are very simple. The roadmap was very simple. You have 6 components for coordination, case management. It depends on where you want to buy. If my NGO or my government want to invest in social mobilization, there's a plan, national plan, and it must be one plan. So it's costed. So you come and buy into the national plan. It's very simple.
You're telling us that the work has already been done. There's a template that exists.
Yeah, there's a template that exists. There are 6 components from coordination, case management, epidemiology, and surveillance, the lab, social mobilization, all these things, 6 different subcommittees. So you fit yourself in where you think you can make an impact. But it must be coordinated. And governments must take ownership. You should start and say, yes, if you don't want to invest, we take your money and go. It's as simple as that.
Thank you very much, sir. Sunita, yes?
Thank you, Dwak, and thank you to His Excellency. I just wanted to maybe emphasize the point made by the eminent speakers in the morning, which is related to domestic revenue mobilization and domestic spending in the health sector. I think it is going to be very important that as we go forward, we try to match domestic investments and reduce investments from partners in the health sector. And that is the only way to have sustainability. And I think that is one of the key lessons that we learned from the Ebola situation, and thereafter the post-Ebola regional response that was presented in also 2014 by the 3 heads of states. I mean, there is always a need for us internally, from your perspective, the country ownership, to also have those investments matching to partners. Because otherwise, as Udwak has mentioned and as the eminent speaker said, at one point, the partners will also have to manage other emergencies elsewhere. So I think this is a question, of course, for the afternoon session or after this session as well. Thank you.
Excellent. On that note, I'll remind us all that it's tea time. I just want to check with our panelists. Is there anything that you would like to share with us before we break for tea? Okay, Madam Momati first and then Dr. Moeti.
Thank you. I understand what is being said. Let me just deviate a little bit and speak like an economist. Sierra Leone, we get our money from iron ore. Before the Ebola outbreak, the price of iron ore dropped. So our economy was already being compromised. And when Ebola struck, we had to use our country's resources before we could get help from the international partners. What my colleague here is saying, you have mushroom NGOs coming into our countries, taking advantage of the system. You have 20 of them doing social mobilization, so you cannot even know what is being done, where the money is being spent, so it goes back to coordination. And that is what we're trying to do now. When you come into Sierra Leone and you want to do social mobilization, we have enough of that now. You can take something else or leave. That's where we are. Thank you.
Good for Sierra Leone. Dr. Moeti?
Thanks very much. I just wanted to pick up on the emphasis on domestic financing, to say that we've learned through different experiences how challenging this is. And I do believe that it needs our creative thinking, and it needs data. It needs real information, evidence to convince those who have to make the right decisions to make them. For example, we've had middle-income countries graduating out of support by Gavi. That's the Global Alliance for Vaccines. Believe me, countries feel pained. The first reaction is, oh my God, we are being punished, we are graduating out. And it's been a real challenge to help some of these countries to establish sustainable ways of integrating now funding for vaccines into their national financing systems. I think that's one lesson. Well, so what would it take? What sort of arguments would it take for a Minister of Finance to recognize and the Minister of Health to make this sustainable? So you can predict you don't have vaccine stockouts. One, we had the huge disaster of the HIV/AIDS epidemic where we had these similar discussions. I remember because I worked in HIV a lot. Our health systems are weak. We need to spend more of our own money on HIV. Of course, we were lucky enough to have a global fund, but and it's had a fabulous replenishment. But one day we'll need to spend our own money on this, prevention and treatment. So I think we need to be extremely creative in thinking, what is it that actually gets those decisions made that translate into investment that is sustained and that goes into health systems. A few years ago, health systems was a dirty word. So I'm very happy that we've moved on from that. Now we need to see the money following that understanding. And I'm sure that's what we'll be talking about in the afternoon. Thank you.
It also sounds like we will be talking about responsibility, maturity, and just growing up and owning our own development.
Just a quick one. You see, one of the observations I made over the 4 years as minister is when I go to meetings and they talk about the Abuja Declaration of 15%. I know we come to that, but I say, for me, if I have a way, I'm going to ask for a repeal. I will ask for a repeal.
A repeal, why?
Yeah. When the scope, look at even in West Africa, for example. Now, nutritional health. That time health was one health. But where is nutrition health now? Where is environmental health? Where is water and sun? Everything has been, and then, so it has to be looked into and see how much is given to health direct. Now you come in countries, we say like, okay, 11% for direct reproductive and child health and all these things. Now you want to talk about nutrition, it's in another ministry or other department. Even in ECOWAS. You want to talk about environment, pollution, and all these things. Public health, intervention, food safety is in another ministry. And yet, I don't know where we are heading to. We have to look into that properly if you want to address domestic funding properly.
Okay, we'll try and unpack all of that, which has been so beautifully laid out for us by this distinguished panel of speakers. Ladies and gentlemen, thank you very much for setting up our conversations for the rest of the day. It's tea time now, coffee, whatever you like. I think there should be a setup outside. We reconvene, I think we're running just 5 minutes over, so we reconvene at 11:45, was it? No, 11:20. That session, when we reconvene, will be an exclusive one. It's a closed roundtable session for health ministers, ministers of finance, executive directors, partners, technical people. So we will not be returning to this room. There should be 1G. We're moving into room 1G at 11:20 after the tea coffee break. Thank you.